have Dr. Darnton here, and he will talk about fentanyl and other synthetic opioids. And then we'll have a 5-minute break. And then we'll have Jared talk about methamphetamine. And then we'll have another 5-minute break, and then we'll do some small case discussions. So just to give you guys a roadmap of the morning. Otherwise, take it away.
All right, great. Thanks, Nina. Hi, everybody. For those I don't know, I'm Jamie Darnton. I'm a primary care doc at Adult Medicine Clinic, and I also work at Evergreen Treatment Services doing addiction med stuff. And I'm really happy to be able to talk to you guys this morning about synthetics. Kind of the overarching theme we were thinking was kind of the new synthetic illicit drugs, which is kind of the newer kids on the block that we're seeing a lot among our patients. So specifically fentanyl and fentanyl analogs and methamphetamines. And Jared Klein and Amy Kennedy, I think they might have to jump on a little late, but they'll be joining us for more. And we're going to start just talking about fentanyl and other high potency synthetic opioids. Please jump in with chat or unmute at any point for questions or discussion. I am going to kind of move kind of fast because I probably have a little too much material for the time, but I do want to, focus on the stuff that's useful and interesting to you guys. So just a little outline here. We'll talk about kind of the pharmacologic properties of fentanyl and kind of a little bit about how and why that it's kind of spread and become at this point, major available illicit opioid. Go a little bit into the epidemiology and then kind of shift gears and talk about what are the clinical implications of this in folks you're seeing in the hospital and in clinic, and how can we try to keep people safe and in treatment if they're interested. So fentanyl, the pharmacologic fentanyl, was synthesized in Belgium by Paul Janssen of Johnson & Johnson fame in 1959. The thought was that a high potency increased agent with increased receptor specificity would be safer, and it's available, as you guys know, as a patch, as a pack-you drug IV as a lollipop, buccal, and sublingual tablets. It is very potent agonist at the mu opioid receptor in the CNS and elsewhere. It's approximately 100 times more potent than morphine and 50 times more potent than diacetylmorphine or heroin. Like a lot of these opioids, it's metabolized by the P450 system and is renally excreted at least partially, which means we can detect it. So that's important. Half-life, we'll kind of go into this kind of important pharmacokinetics that we'll spend a little more time on later, but in acute use, like in the PACU, it's a great agent because its half-life is similar to oxycodone. Its mu receptor affinity is it's a little higher, but similar to oxycodone. But it's very lipophilic, which accounts for some of its properties. So it's got a faster onset of action for that reason. It can cross the blood-brain barrier more easily, and a shorter duration of action because it then rapidly redistributes to the fat and other tissues. So quick on, quick off, which is a great property in a perioperative setting. Now, when it's used chronically, it's a different story, and as we'll see, it kind of sequesters in the fat in the adipocytes, very similar to THC, and that can kind of cause some problems, as we'll see when you're trying to start buprenorphine. Let's see if there's good. I'm just trying to kind of keep an eye on the chat. So illicitly manufactured fentanyl analogs. So seizure data has detected a whole bunch of different fentanyl analogs in addition to kind of the parent moiety. And carfentanil is one that's gotten a lot of press because it's such a kind of terrifying potency. It's used in veterinary medicine as a like an elephant tranquilizer. And you guys may have seen this popular image on online that kind of shows roughly equivalent doses of heroin, fentanyl, and carfentanil. And this is data from National Forensic Labs looking at law enforcement seizures of there's just a whole bunch of different analogs out there that probably have different pharmacokinetic and dynamic properties. I don't know if you guys saw this. This book came out at the end of last year by Sam Quinones. He wrote in 2015 Dreamland, which is a really great account of the prescription opioid crisis. And he kind of turns in this account to fentanyl and meth. And it's an interesting work of investigative journalism, really focuses on kind of as a crime reporter, rather than the medical angle. But he kind of describes how drug producers, primarily in Mexico, learned the value of synthetic drug processing from methamphetamine in the late 90s, and they kind of applied those lessons to the opioid trade. In 2006, there was the first kind of wave of fentanyl deaths. It was in suburbs outside of Chicago, and they were actually able to trace it back to a specific lab outside of Mexico City and a specific organic, kind of rogue organic chemist down there. And they were able to shut down the lab. They scheduled some of the precursors that were coming into Mexico, and the outbreak came to an end. But in 2013, we started seeing more deaths on the East Coast, fentanyl-related deaths on the East Coast, and it just exploded from there, such that 2 years later, synthetic opioids surpassed heroin opioids as far as causing overdose deaths. And that continued to diverge, that continued to drive the overdose crisis. I'm sure you guys have seen this kind of graphic summary of that story, where all opioids are represented here on the green, but there's kind of these kind of three phases of what's driving that increase in opioid deaths over the last 20 years. And in purple here, throughout the aughts, it was really this prescription opioids, oxycodone, et cetera, driven multifactorial reasons, but driven in large part by overexuberant prescribing from the medical community. And then in 2000, when that started to kind of level off in 2011, 2010, it was kind of more than made up for by increase in heroin deaths. And then, as we saw in 2015, this kind of scary, this line with the scary slope is the fentanyl analogs, and this has continued to increase the last 2 years and is driving in large part the overdose epidemic. This is from a DEA report from 2020 that's just kind of highlighting the multiple routes that how fentanyl kind of enters the country, and that in general, that either the fentanyl itself or precursors are synthesized in East Asia or South Asia and come over. And what the least of us kind of documents is probably the major route of smuggling, which is precursors coming to Mexico, where they are either admixed into heroin, which was more common in kind of the 2013 to 2016 era, or pressed into counterfeit pills, which is probably the major way that fentanyl is introduced into the United States right now, and then distributed through pre-existing smuggling routes, along the highway system in the U.S. Why synthetics? Why this change to fentanyl? It's really driven probably by, it wasn't a demand, there wasn't a demand for this product. It was really driven by all the benefits that this type of production confers on the producers and suppliers. It's easier to produce, it's cheaper, it's less easily detectable. You don't need a lot of land like to grow poppies. It's more reliable. You don't have to wait for a growing season, and the chemical precursors are abundant from chemicals used in multiple major industries. So it's really hard to regulate the precursors without seriously affecting the economy. And it's easier to smuggle due to high potency. This is the kind of so-called iron law of prohibition, the idea that if a substance is illegal, it's going to be seen in the illicit market in higher and higher potencies because the incentives are aligned. easier to smuggle in, you know, a brick of fentanyl the size of a phone than a wheelbarrow of heroin, for example. And then there's probably this broader market. There's kind of a perceived safety of something that looks like a pharmaceutical product, a pill in our society, you know, versus a powdered product. And then you guys are well aware that we passed kind of that grim milestone of 100,000 overdose deaths at the end of last year. We're still on the upslope. You know, we're all used to looking at these epidemic curves for COVID, and we're still on the upslope of this epidemic, of this, you know, 20-year epidemic. 75% of those, so about 75,000 of the 100,000 deaths were involved opioids, and 63%, so 63 of that total, 63,000 involved synthetic opioids, so fentanyl or fentanyl analogs primarily. And while this used to be an East Coast and Midwest problem from the 2013 on, it is now fully a West Coast issue as well, as was expected, and we had over 50% increases in fentanyl-related deaths. I think this was in 2020, and that trend has continued, as I'm sure you guys are seeing in the hospital when you talk to patients about what they're using. And here in King County, it's pretty alarming. So this is broken down by quarter, the overdose deaths that involve fentanyl. In 2021, there were 373, so more than twice the number from 2020. Already just a month into, I just pulled this data yesterday, just a month into 2022, we're on track to keep track or exceed 2021. So here's this represented in a line graph. The dark blue is fentanyl. The other scary one, of course, that we'll get to next is methamphetamine. So methamphetamines are increasingly implicated in overdose deaths in our county, both combined with opioids and as the only major ingested drug during an overdose-related death or drug-related death. The DEA, oh, sorry, there's a chat here. Fentanyl synthesis happening in the US. I think so. You know, I don't know the answer to that. I think there probably is fentanyl synthesis happening in the US. I think the kind of large scale industrial processes are happening outside of the reach of law enforcement in the US. So, but you would imagine there would be some, but I can't really speak to that. You know, for methamphetamine, that was the case in the 90s. There was a lot of in-country synthesis, and the regulating ephedrine really shut that down. And now, primarily, like the fentanyl, most of methamphetamine, most of this kind of industrial grade methamphetamine is also produced outside of the country. So the DEA released this last year, kind of rare for them to send these out, but it was basically sounding the alarm about specifically counterfeit pills, these kind of pills, these pressed fentanyl pills that are designed to look like M30s. So they call them M30s or Perk 30s or blues. And these are very, very widespread and pretty universally contain fentanyl. And then they have this little thing here that their testing revealed that 2 out of 5 of these pills contained a potentially lethal dose. So I'm assuming they're thinking if you're an opiate naive person, but I don't know how they define that, but okay. So this is just more, so it's not just the M30s, there's counterfeit. So these are real pills on the left and seized counterfeit on the right. You know, the Xanax, there's counterfeit Adderall that also contain fentanyl. In King County, this is data from 2020. It's kind of interesting. So basically, where's the fentanyl in our county? And the big caveat here is that it changes so rapidly. So this is just the state of affairs from January to September in 2020. But at that time, most of the fentanyl that they found in all the stuff they tested was in tablet form. So, here's the tablet form here, residue and missing. That's not very helpful, but tiny little bits were found in some of it was found in black tar and powder, but the vast majority of fentanyl that they found was in the form of tablets. And then if you look specifically at black tar heroin, most of it at that time was actual heroin. Only 1% contained fentanyl. Most of the fentanyl in our area as of September 2020 was in the form of these blues or M30s. Okay, let's shift gears to clinical considerations. Any other comments or questions about any of that before we move on? Yeah, throw them in the chat or jump in, but I'll keep going because I know we're kind of pressed for time. So overdose, we talked about, a lot of it's telling that we've had this discussion, a lot of times when you're talking about trends in the illicit drug market, you look at seizures from law enforcement to detect trends, and rarely is overdose deaths kind of the first indication that there's a new or troubling drug on the market, but that is the case with fentanyl because of the increased risk of overdose. And we'll look at why. For one thing, they happen quicker, so it's usually about 20 to 30 minutes after use of heroin that someone might reach the point of respiratory depression causing death. But that can happen in minutes with fentanyl use, particularly IV fentanyl use. Oh, here we go. Paul's asking, are there other counterfeit non-opioid benzodiazepines, gabapentin, that patients might be getting and laced with fentanyl? I think so. At this point, I basically am letting patients know that unless they get a pill from the pharmacy, they should have a very high index of suspicion that it contains fentanyl. If they're getting it from someone on the street, there's designer, but we're not going to touch on this. There's new kind of synthetic designer benzos that are circulating in Canada, and so there are other substances out there, but fentanyl is admixed into a lot of these different pills that are available illicitly. Synthetic THC, I don't think so. There's been there's rumors that circulate every now and then that there's fentanyl in adulterating marijuana supplies or synthetic cannabis supplies. I don't think those have been borne out. So I think thankfully we're the main focus of in terms of counseling patients, I think, is certainly powders, but also any pill. And I think that's particularly important because it may not be, I think patients are learning that and the community is learning that, but it's not immediately apparent that this pill might contain an incredibly variable, impossible to know dose of a highly potent opioid. And then this is bullet 2 is really the main issue here. It's very potent and you just don't know how much is in it, and it's very variable. It's being kind of mixed in God knows what fashion. And so you could have a extremely high lethal dose in a pill or a very low dose, and there's no way to know. Folks may not know that they're using fentanyl or that it's adulterated with fentanyl. If stimulants, those Adderall pills or cocaine or methamphetamine is adulterated with fentanyl, then a stimulant user who might not have opioid tolerance, that's another risk for opioid overdose. And then there's this kind of rigid man syndrome, this chest wall rigidity that's been described since in the anesthesia literature in the 60s, and that maybe that could complicate CPR. I'm not sure about that. So naloxone has a higher affinity than fentanyl. It works for fentanyl overdoses. We need more data here, but there is the suggestion that we might need more doses than we typically have in the past. And there's this survey interview of several respondents in the community who 83% of them, this was in Massachusetts, reported they needed more than 2 naloxone doses before the person responded. The Narcan formulation at that time was 2 milligrams, so nasal spray. So that's half the one that is in wide usage here in Washington. Washington State, basically, the Department of Health has been trying to put out the messaging that you should treat any potential opioid overdose the same. In other words, call 911, administer a dose of the intranasal Narcan, rescue, breathe, and keep, if they haven't revived in 2 minutes, do that whole thing again and keep doing that until EMS arrive. So there's not yet any change that we need a higher initial dose of Narcan or anything like that. And then when you're counseling patients about overdose prevention, I think the stuff we've gone over is really the important stuff to convey. Basically, that they're pretty much guaranteed that if they have a pill that they get on the illicit market, that it's going to contain fentanyl. They shouldn't use alone. Don't use simultaneously, particularly if you're using it intravenously. There's been numerous case reports of people who were using in a group to be safe, and everybody overdosed in that group, fatally overdosed in that group. Tasting or using a small test dose to judge potency. Minimize mixing with other sedatives is always good advice, and be aware of potential for unintentional exposure in the opioid naive if you're using stimulants, for example. Oh, great. Thanks, Jared. Yeah, Jared's mentioned in the chat that each box of the intranasal Narcan that you guys may have seen. I've got one here. My box is kind of beat up, but it's got 2 doses of the 4 milligram doses in there. But I think it's probably a good idea to prescribe multiple doses with refills, in the fentanyl era. Okay. So now, what about fentanyl testing? Oh, I'm going to have to speed up a little bit here. Sorry, guys. So fentanyl testing is you can use these immunoassays not only to test. So fentanyl drug screening. This is just to say that you need a special immunoassay to screen that. Our system in Harborview, at least now, does that for as part of the standard immunoassay drug tox. But that may not always be the case depending on where you're practicing. Boston Medical College did a study looking at the positive predictive value of the fentanyl assay. There are false positives. It can cross-react with some antipsychotics and trazodone and fluoxetine and other things. The positive predictive value was 85.7, and that, of course, is dependent on the prevalence. And that was in a sample where 9% of all the urine drug screens contain fentanyl. So it's like other testing. The immunoassay is pretty good, but you may need to confirm it with chromatography, more specific confirmatory test if there's questions about that. And then some of the fentanyl analogs may or may not cross-react, so you may not detect some. And then this immunoassay testing can be used to test the drug supply, and public health in King County is really kind of leaning into this, and a lot of syringe service programs are dispensing these. Harborview's office-based opioid treatment program, I believe, is still dispensing these. Evergreen Treatment Services is dispensing these for patients to test their supply. And you can basically break down a little bit of your supply and kind of dissolve it in water and see if it's it's a qualitative test, yes or no, for whether it contains fentanyl. There's not great data on whether this helps reduce overdoses. I think there's the hope and expectation that it may. This is just a survey from a couple years ago, actually, that looked at people reported changing their behavior when they tested positive. So 75% of people used it, who were dispensed it, used this test kit. 50% of them had a positive test. And then most of them described changing their behavior, using less, using around someone else, going slower, doing a tester, etc. I think the caveat if you talk to patients who have these, you just want to be clear that you don't want people to get false confidence from a negative test. They could test a portion of their pill that does not contain fentanyl. It doesn't mean that the pill itself does not. And so I think to me, the main value of this is it's a great way to have that discussion about how dangerous the drug supply is right now. But you want to make sure that someone knows, okay, if your supply test negative, don't throw caution to the wind, still take precautions, because it probably still contains fentanyl. It's just not in the little sample that you tested. So let's turn quickly to treatment. So, even though this has become a predominantly available opioid in many communities, it's under tested as far as response to treatment. There was a retrospective study out of an opiate treatment program in Rhode Island that basically looked at people's intake urine drug screens, and they stratified people if they contained fentanyl only, fentanyl and other opioids, or other opioids only. You can see already how prevalent fentanyl was here, that the folks using heroin or other opioids alone were in the pretty slim minority. And basically the factors that we care about were not statistically different. So the retention at 6 months was about 70% across all the groups, not significantly different. Achieving abstinence or 3 consecutive urine screens without illicit opioids was about the same in all the groups. And the dose required, the therapeutic dose of methadone, was about the same, 90 to 100 milligrams in all the groups. And then the rate of relapse being common in substance use disorders, was similar in the group. So, suggesting that approach to treatment it may not be all that different when you're talking about methadone. There's a similar study out of Boston for buprenorphine, 250 adult patients enrolled in an OBOT program in Boston. And this was not, they looked at admission drug screens, fentanyl, heroin, or negative for opioids. And retention and treatment was similar, maybe a trend towards higher retention in the heroin group versus the fentanyl group. Percent abstinence was similar. And there was no mean difference in the mean buprenorphine dose required. I will say that anecdotally, you hear a lot of talk about people in opioid treatment programs on the East Coast whose drug of choice or main substance of use was fentanyl, needing higher doses. So I think the jury's kind of still out on that. But it's kind of like anyone with an opioid use disorder, you want to kind of up titrate your treatment dose until you achieve a therapeutic result. Now, let's turn a little bit to some induction challenges unique to fentanyl for buprenorphine. We talked a little bit about how the half-life, is on the order of hours in a lot of the early pharmacokinetic studies, but that's for acute use, kind of in the PACU setting. With chronic use, it does accumulate in the adipocytes and can kind of sequester there and take longer to leave the system. This is from a qualitative interview with drug users who were using fentanyl and trying to get on buprenorphine. And in the interest of time, I won't read through them, but they describe waiting long periods of time, 72 hours, 80 hours, being in withdrawal before trying to induct onto buprenorphine, and then having terrible precipitated withdrawal. I just will read this part from the second quote. I precipitate withdrawal every time I try to get off the fentanyl. Then I have these sub doctors telling me that it's not real. And it's like, go ask the people who are buying off the street. It's real. I waited 80 hours. I was in detox. And after 80 hours, they gave me a Suboxone and it still put me into precipitated. I think this quote highlights that this hasn't necessarily permeated to the consciousness of clinicians. You know, folks are saying, well, that doesn't make sense. But this is, you know, we're getting increasing evidence of this phenomenon. I won't spend much time on this. Basically, there was a study looking at a sleep medicine for opioid withdrawal, and they had a pretty standard induction routine, but they had to alter it because they were precipitating withdrawal with their standard induction routine. In folks who used fentanyl. And I don't think it's worth it. It's kind of confusing, so I'm not going to actually go through and explain it. This is another study that looked at, these were people who were enrolled in a 28-day residential program, and all they did was test their urine every day. You know, oxycodone, you'd expect fentanyl like oxycodone to clear in like 2 to 5 days, but the parent compound was detectable in the urine for a week, and norfentanyl, the active metabolite, was detectable for 2 weeks. So it's taking longer to clear in chronic users. And this is a study from Journal of Addiction Medicine from late last year, just surveyed people who described using buprenorphine within 20 and methadone within 24 hours of fentanyl use, within 48 hours, within 72 hours, and what the risk of, you know, how many experience withdrawal. And it's, you know, close to a quarter described having that experience of withdrawal when using within 24 hours. Interestingly, they also described it with methadone, which may have more to do with, you know, lower, inadequate initial doses of methadone, which are required by law. You know, you have to kind of start slowly with methadone. And then I'll just touch on concept that I think you guys are aware of from inpatient inductions of microdosing. This idea that if you kind of if all your receptors are occupied by a full agonist and you take a high dose or a moderate dose of buprenorphine, you're going to displace that full agonist, replace it with a partial agonist, and you'll experience that as withdrawal, as precipitated withdrawal. Whereas if you kind of ease that, gradually increase the dose of Suboxone and ease it onto the receptor, you can pretty quickly occupy, you know, after a number of days, occupy all those receptors and not experience precipitated withdrawal, and also not have to go through that kind of washout period. You guys have probably seen that in transitioning folks from methadone to buprenorphine in the hospital, or on full agonists for pain in the hospital who need to start on buprenorphine. But there's increasing interest in using this technique for folks using illicitly manufactured fentanyl. And I will say it's been understudied. It's a pretty complicated regimen for folks to take on their own. So I think we still need to kind of get more data about how best to do this, but I think this is probably an area that needs to be more studied and is being studied. There's a large RCT enrolling comparing microinduction to standard induction, and I think, or at least I hope, they're looking at fentanyl use in that population. So just a kind of cool case study I saw where they were able to convince a pharmacy to blister pack their microdosing titration, which would make things easier for patients because it's a pretty complicated regimen. So take-home points: adulteration of the drug supply with fentanyl and other high-potency analogs is a major driver for increasing fatal overdoses. And our state and other states in the West and our county, as you saw, is kind of the fentanyl crisis has reached us, no doubt about it. Tablets and pills obtained illicitly, particularly the blues or M30s, should be assumed to contain fentanyl. People who use drugs, should be counseled about the risks of using alone, counseled to consider testing their supply, carrying naloxone, and treatment with methadone and buprenorphine is effective. Higher doses may be necessary, and buprenorphine induction may be a little more difficult for some patients. And these are my references. And I see a couple more comments in the chat. Oh, thank you. Yeah, Jared is, the term microdosing is a little confusing and applied in a lot of different settings to mean different things. And I think the consensus term is low dose initiation is now kind of the preferred nomenclature for that. How does someone get access to fentanyl test strips? So the county is distributing them to syringe service programs. So I know that there's a lot of folks in the residency. I don't know if anybody on the call now is engaged with PRA or Downtown Public Health Syringe Service Program. My understanding is they are dispensing those at most of the syringe service programs in Seattle, or at least they were. Actually, the adult medicine clinic similarly was. Do you know, Jared? Do we still have that in supply that we're dispensing those?
Yeah, there's a limited supply that are funded. They're grant funded. Basically, you have through a SAMHSA grant. I was just going to comment the challenge. So most syringe service programs have fentanyl test strips. So the challenge, obviously, with that is that most fentanyl is in pill form that folks are folks are smoking, excuse me, or maybe swallowing, but most commonly smoking. And so those folks may, if they're not also injecting, they may not be accessing services at the syringe service program. So it's a little bit of a challenge right now. And I think that there's discussions around about how to expand the availability of fentanyl test strips and just other harm reduction things like smoking, equipment for smoking, et cetera, at different sites in addition to syringe service programs, just so those safe use equipment is available where folks need it when they need it. But that's challenging.
Yeah, and thank you, Jared. That brings up an important point that I didn't really touch on with the epidemiology, was that it's looking like, at least from kind of survey data from ADAI, that the major route of ingestion or using this is inhalational, and that has all sorts of implications as far as infectious disease and disease transmission and such, but also in terms of engagement and outreach. When traditional syringe service programs are really geared around providing safe injection equipment, so kind of requiring a pivot there. I'm over my time.
Oh no, you're good. I think we were going to take a break until 9. And come back around 9:45. So let's do about 5 minutes if that works. And then talk about meth for a bit.
Sounds good, Jared.